Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Dr. Malinda Itchins. I'm a medical oncologist at Royal North Shore Hospital and Chris O'Brien Lifehouse. The Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. We pay our respects to their elders past, present and emerging. We also extend that respect to all Indigenous people. In today's episode, we're exploring liquid biopsy, the advantages, the limitations, the clinical applications in lung cancer. As we're probably all aware, at the moment in Australia and New Zealand, we don't yet have access widely to liquid biopsy, but we're pleased to see there is in Australia an MSAC application currently under review. So with that, we'd like to thank our sponsors for the podcast, AstraZeneca, Daiichi Sankyo Australia, SOPHiA Genetics, and Thermo Scientific for sponsoring this podcast. Today on the show, we're excited to have two colleagues. First being Dr. Annie Wong, a medical oncologist at Wellington Blood and Cancer Centre and senior lecturer at the University of Otago and University of Auckland. She's the Deputy Chair of New Zealand's Lung Oncology Special Interest Group.
Thank you for having us.
And our second guest is well-known colleague, Associate Professor Stephen Kao, a medical oncologist from Chris O'Brien Lifehouse. Stephen has a keen interest in clinical trials focusing in the thoracic oncology space and translational research in mesothelioma and lung cancer.
Thank you, Mel and Annie, for having me.
I'd like to welcome you both to TOGA's Conversation in Lung Cancer Research podcast. And I'm really looking forward to discussing today with you both your expertise and insights into liquid biopsy. So an important place to start the podcast is to establish what is actually meant by the term liquid biopsy. Annie, did you want to take this question?
Sure. Thanks, Mel. So liquid biopsy is quite a broad term to think broadly about a diagnostic test that can detect circulating tumour DNA or circulating cancer cells or exome, or as a way of helping us with clinical decision making. And so I guess front of mind, we're thinking about trying to find oncogenes in the advanced setting as a diagnostic test, and also more and more it's become important to find molecular or minimal residual disease in the early stage.
Thank you. I guess we could all think of some advantages to access to liquid biopsy for individuals with lung cancer. Stephen, do you want to take us through some that come to mind for you?
Yeah, I guess the obvious first thing is that we all know that treating cancer is based on accurate diagnosis, right? And we know that for some people, for whatever reason, there may be difficult access to tissue or due to comorbidities of severe lung dysfunction where you don't want to cause a pneumothorax. For whatever reason, there may be limitation in us getting traditional tissue biopsies. In that setting, I suppose, liquid biopsy is very useful, although it doesn't tell us exactly what histological cancer we're dealing with. As Annie said, it provides very useful information for molecular characterization, whereby, if we found a targetable mutation, we can potentially use a very effective targeted therapy for that particular patient without that tissue biopsy. So to me, that's probably one of the, the biggest advantage. And of course, in that mechanism of resistance where we want to figure out whether there are other targeted therapy after the initial mutation. Again, if the tissue is difficult, bone biopsy, we know notoriously that decalcification can destroy the DNA for mutation testing. In that setting, that is very useful as well.
Agree. And I think from the international data, it's been particularly good to see that perhaps with liquid biopsy, we can see a faster turnaround time potentially to diagnosis, getting people started on therapy faster. And I guess you've alluded to the fact that there's a concordance with liquid and tissue. So it's certainly a reliable result if it's positive. Annie, did you have any other advantages that spring to mind?
Yeah, I guess when we're trying to think of access for our patients, we're under quite a health resource constrained access to specialist care. I think liquid biopsy poses a good complementary test, particularly if you are thinking about community-based. It might be particular populations, so say the Indigenous population in New Zealand, the Māori, or the First Nations in Australia. It might be a more approachable and more accessible way for patients to get that diagnostic test. So that's one. I think the other aspect is that some patients who are very comorbid, like Stephen was saying, some of them don't wish to have a very invasive test, especially when they're thinking, I'm frail, I've got other comorbidities, and doing that invasive test might actually cause more problems. So it is a very good alternative.
Agree. There are some advantages potentially, as you say, in equitable access to diagnostics and then the therapeutic space. So, of course, like everything, there are limitations to these types of, panels we're seeing coming through in the liquid biopsy ctDNA space specifically. Stephen, limitations-wise, do you want to take us through some of our considerations?
Look, I think the first thing is to think about, I suppose in my mind, sensitivity of a particular test. Obviously, it's novel. One is, other lab, the technology being accredited for, optimal sensitivity of the test. So to me, sensitivity is a big thing. And I guess we do know from clinical data that if the burden of disease is low, then the sensitivity of liquid biopsy goes down. And that makes sense. If there's not a lot of circulating DNA, you may not get the result that's there. And so you might get a false negative in those results. And I guess we also know that from studies that if your disease is predominantly intracranial, then it may not shed ctDNA as much as if somebody's got hepatic metastases. And so there's certainly limitation in terms of sensitivity, not just the technologic kind of reasons, but the disease-specific reasons as well. And so you sometimes need to interpret those negative results with some caution, depending on the clinical features of the patients. And I guess the other thing that I have learned over the years is that there's this phenomenon called the CHIP, or clonal hematopoiesis of unknown significance, where as an age-related thing, because DNA is not just from the tumor, right? Our own age-related degradation of cells can share our own DNA. And so we know that there's some age-related DNA that could be mistaken as a pathogenic driver mutation sometimes. And so I think from my experience, though, the reporting has become much more specific in letting the clinicians know whether certain mutations that's being reported may be a chip or whether it's actually pathogenic. So I think that's the other thing that we just need to be aware of liquid biopsy technology.
Yeah, absolutely. I guess the other important point to make is that our tissue pathological diagnosis is still really important in lung cancer, where it can obviously be safely obtained. And in most cases, not all, we are able to get a tissue diagnosis. So I would be looking at liquid as a complementary test, or if, of course, that biopsy is not safe. So Annie, let's talk about some clinical scenarios. Can you take us through some where you really see liquid biopsy having a role in our lung cancer clinic?
I think for patients with advanced disease, where like you already alluded to, where the biopsy is not safe or not anatomically possible, I think that's a very good use. Someone who is unwell, where you want the turnaround time is very quick. I guess you have to have a situation where you are able to prescribe treatment on the basis of the result. And I guess that's a problem both in terms of access to medication or access to treatments, I guess another clinical scenario in the early stage that's post-operative, when you're trying to decide about adjuvant therapies now, there's a lot of interest in terms of disease monitoring in that early setting, and also looking for disease recurrence as well. I think there's some interest in using it as a complementary test for screening, right? But of course, you need a completely different type of assay that's much more sensitive than what we would do in the advanced setting.
You're right. I think it seems more methylation type panels in the screening space. The minimal residual disease research coming through is really exciting. I guess thinking about how we then move these types of technologies into the routine clinical practice does present some questions. Annie, what do you think about the data we've seen so far with the tumour-informed panels in those early cases versus the tumour-agnostic? Do you think we're nearly there yet to start moving it into real-world clinic?
Yeah, I think there's a number of challenges even when you hear, so some of the industry-sponsored studies like ADORA that was presented at ASCO by Tom Johns. It was very interesting to see that a tumor-specific or tumor-informed assay could be used, but that only pertained to a subset of patients. So they weren't able to generate a tumor-informed assay for everybody. And also, I think the patients, there was some concern about germline testing and what the implications would be on their, say, insurance or other aspects of their healthcare. So I think there is some limitations both in the assay itself as well as how it applies to our patients in clinic. So it's a really exciting space for sure, but I guess standardizing and making sure that it's available for everybody is a big challenge.
And your point to requiring tissue for accessing reimbursed drugs is a good one. And obviously, if we see liquid biopsy come into routine reimbursed practice, that would really need to change.
It's surprising that in New Zealand, that even though our access to treatment is really poor, our pharmac is actually quite on board with the science. So they see that if you can identify the oncogene on liquid, that's enough to get a reimbursement for the drug, both in treating for osimertinib or alectinib. And then in the resistant setting, if we can set T790M, then you can use osimertinib in the second line. Not that that's a problem for you guys.
That's really reassuring, obviously, to hear. I think in the resistance space, we're hopeful liquid biopsy can help us understand next generation inhibitors and the right next therapy. But until we see new therapies coming through, it's going to be interesting how we apply that again in the clinic. So, Stephen, the difficult question is for you, what do you think the barriers for the use of liquid biopsy are in Australia, and how are we going to overcome those barriers?
Look, I think the obvious barrier is obviously that there is no reimbursement for the test. And so it's really difficult to, I guess, in a way to access this unless patients have the means. We know that the typical commercial assay can cost up to 3,000 Australian dollars a pop. And that's not always within reach of our patients. And so I think when you work in a big center, we're kind of spoiled where there might be clinical studies where patients can access it. But that equity to a potentially useful test is the problem, I think, at the moment. Now, how do we overcome that issue? I think it's obviously very difficult. I think it requires all of us to advocate for our patients for, potentially, this useful tests. And I'm glad to hear that, that is being put in to MSAC for consideration. But I think we need to, individually and as a group, we probably need to make more noise to advocate for this to be reimbursed.
Agree. And I know that the Toga Consumer Group are also very vocal with their support for the reimbursement. Just finally, actually, we might step back to early stage disease. And Annie, you spoke on the ADORA data and how it may be informative in predicting for recurrence to come in those patients that completed their adjuvant osimertinib. to both of you, and first perhaps Annie and then Stephen, has there been any other encouraging data you've seen to support liquid biopsy in the early stage disease space?
I don't know. So far, the data I've seen is that it heralds a clinical relapse. I'm not sure that I've seen specific data to where you can use the assay straight away postoperatively to help us decide whether to put someone on adjuvant treatment or not. I mean, I guess Toga is running this study Oceanic that tries to address that a little bit about whether certain co-mutations are relevant in helping us decide what type of adjuvant treatment to do. I mean, I think I'd be really excited to support that type of study. I don't know, Stephen, what do you reckon?
Look, I think in the early resectable disease with a myriad of immunotherapy trials, both, neoadjuvant studies and adjuvant studies, there's been some liquid biopsy or ctDNA being performed to inform the likelihood of relapse. And so I think there's that concept we've talked about before of minimal residual disease, meaning whether we can detect ctDNA, right, on the liquid biopsy. So I think in that Checkmate A16 study, they showed that the lack of ctDNA at the end of neoadjuvant 3 cycles of chemo-nivo, the relapse rate is substantially lower compared to people who have detectable ctDNA. And similarly, I think the AGN study also showed similar result, where if there's no ctDNA detected at the end of it, you have a higher pathological complete response. And the adjuvant setting, that Empower 010 study, I think detection of ctDNA predicted for more likelihood of relapse as well. I think the problem with all of this study, in my mind, is the sensitivity is not great. So that means that if you don't detect ctDNA, it doesn't mean that they're not going to relapse. And so I'm not sure that we're there yet, that just because I have a ctDNA negative patient after surgery, that I'm going to tell them not to have adjuvant chemotherapy if they have stage 3 disease, for example. And so I think that's probably the current limitation interpreting those data. And I guess the other thing is we've got very good predictive results of, we've got ctDNA still after, all our curative intent treatment. But what do we do with that result? We don't have data to say adding more chemo or adding more immuno or adding more longer osimertinib is going to improve outcome. And I think that's really the next step, thinking about, we know that it's not good for patients with those positive ctDNA. We need to kind of think about what we do to change that. And I suspect that technically we'll need more randomized study to look at how we can improve outcome. But I think that, to me, is the difficult part of it. But I think that utility of ctDNA, I'm fairly convinced about, how it, what information it tells us in terms of prognostic information. What do you think?
No, they're really good points. I mean, I think the future direction for liquid biopsy, we would all love to see, as you said, the data generating an ability for us to escalate and de-escalate therapy, stratified by risk, enabling also potentially in an important population, minimal toxicity, even in an advanced setting, those who clear, their plasma and their ctDNA, even future thinking towards, therapeutic drug holidays, or at the time where their plasma may become positive with also a number of variants, whether they then need an escalated combined therapy approach. I mean, that would be so exciting. But I agree, these studies are hard, and especially when we're talking about potentially rare subsets of oncogene-driven cancers. Well, that brings us actually to the end of the episode. Thank you so much, Annie and Stephen, for joining in an interesting discussion today, and something that's certainly on our prospective agenda.
Thanks, Mel.
Yes, thank you for having us.
And once again, thanks to AstraZeneca, Daiichi, Sankyo Australia, SOPHiA Genetics, and Thermo Scientific for sponsoring this podcast. And as always, thank you for listening to Toga's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify. Thank you.